In this video, we'll discuss about NSAID overdose and poisoning. NSAIDs are competitive inhibitors of the enzyme cyclooxygenase. So by inhibiting this enzyme cyclooxygenase, they inhibit the synthesis of the prostaglandins and thromboxanes. This COX enzyme has two isoforms, COX-1 and COX-2. COX-1 is a constitutive enzyme and it's expressed in most of the tissues in the human body, and it enables the regulation of basal cellular homeostasis like platelet function, maintenance of the gastric mucosal integrity, and it also helps in the regulation of the renal blood flow. Whereas COX-2 is an inducible enzyme which increases during inflammation and the pain states. So most of the side effects and the adverse effects related to the NSAIDs are attributed to the COX-1 inhibition. So for most NSAIDs, ingestion of the dose less than 100 mg per kg is unlikely to cause any significant toxicity. Massive overdoses that produce severe clinical toxicity are seen with the ingestion greater than 400 mg per kg for most of the NSAIDs. NSAIDs are absorbed almost 100% after the oral ingestion, and the peak serum levels they usually occur within 1 to 2 hours. Sometimes the peak level may be delayed because of the large toxic ingestions or when they are concomitantly taken with the food. The NSAIDs are weak acids that are extensively protein bound. So because of that, they have very small volume of distribution. However, disease that cause low protein levels or when patient ingests large dose of NSAIDs, this decreases the plasma protein binding and increases the volume of distribution, leading to the increased penetration into the body tissues like central nervous system, leading to toxicity. NSAIDs are metabolized by hepatic biotransformation with urinary excretion. Half-life depends upon the compound. NSAIDs like ibuprofen, indomethacin, ketorolac, they have short half-life, whereas NSAIDs like naproxen, phenylbutazone, they have the longer half-lives. When NSAID overdose or poisoning is suspected, history and physical examination is very important. We need to ask about the name of the NSAID ingested, amount ingested, time of ingestion, presence of the co-ingestants like acetaminophen, aspirin, alcohol, or any other compounds. Because these acetaminophen and aspirin are usually commonly mistaken for the NSAIDs, and if the diagnosis is missed, it can lead to the significant toxicity. The patient can present with various clinical manifestations. The patient can have general manifestations like nausea, vomiting, drowsiness, blurred vision, dizziness, or hypothermia. They can also present with the acid-base disturbances leading to the increased anion gap metabolic acidosis because of the lactic acidosis and because of the weakly acidic NSAID metabolites. Similarly, because of the acid-base disorder and the electrolyte abnormalities, patient can present with the cardiac dysrhythmias as well. NSAIDs in the toxic dose can cause AKI and the renal papillary necrosis, so patient can present with the manifestation of the renal failure as well. Sometimes patient can have hypotension and cardiovascular collapse. Similarly, sometimes patient will present with the features of CNS toxicity like coma, ataxia, nystagmus, disorientation, and even seizures. Some NSAIDs like phenylbutazone and indomethacin can cause hematologic toxicity like aplastic anemia and granulocytosis. Similarly, almost all the NSAIDs can cause coagulopathy as a idiosyncratic reaction. Similarly, NSAIDs can worsen the chronic urticaria and are sometimes responsible for the anaphylaxis as well. So in every suspected cases of NSAID poisoning or overdose, we need to check the finger stick glucose. Similarly, acetaminophen level and salicylate levels should be done to rule out acetaminophen and salicylate poisoning. Similarly, ECG test is very important. Pregnancy test needs to be done in all the women of childbearing age group. Similarly, renal function and electrolytes should be measured, and the ABG will give information about the presence of the high anion gap metabolic acidosis. Similarly, if available, we can do the NSAID serum concentrations, and this can also help in the diagnosis. However, this test is not easily available in many countries. Differential diagnosis is broad, however, we need to rule out aspirin poisoning and acetaminophen poisoning in all the patients with suspected NSAID poisoning. Talking about the management of the acute toxicity of the NSAID is usually supportive. There is no specific antidote for the NSAID poisoning. If patient presents within the 2 hours, gastrointestinal decontamination can be done with the activated charcoal. Similarly, airway breathing and circulation management and other supportive cares are very important. And one important thing to note is that ECMO or hemodialysis is not effective in the NSAID toxicity because of the high protein binding of the NSAIDs. So the treatment is mostly supportive. Thank you so much for watching. Please subscribe to our channel for more videos.